Hello. Hello?
Hi, welcome. We're going to get started in just a few minutes.
Okay.
Well, good afternoon, everyone. We're going to get started in a minute or so. Everyone is muted right now. If you want to talk, you can either use the raise your hand button down on the bottom, or you can add a question into the chat. But we'll do introductions in about 1 minute. Where's the raise your hand thing? I don't know, it was there yesterday or last.
If you pull up the chat, you can see it. Yeah. It's somewhere over here.
Huh. No, it wasn't right here. It was there.
I'll be monitoring the chat.
I'm having a blank. You're with the Family
Development Center.
Thank you.
Mm-hmm.
I was trying to think of the other piece that we had.
Where's that located?
St. Paul. Like right kind of on that border of Minneapolis, St. Paul by 280.
Oh, you're right by our
That's where
wellness location.
outpatient is.
Our young university?
Mm-hmm. Like right on, like a little bit in from University on Cleveland Avenue.
Yeah, that's exactly.
So yeah, she's right over by the Minnesota non-smokers where you go up and.
Where are you?
Sherritt's. Are you above Sherritt's liquor store?
No, right down so that's Raymond and University.
Mm-hmm. Yeah.
Oh, you're down at
Cleveland and
Cleveland.
University.
So we're at Raymond and University.
Okay. Yeah.
Cleveland is right.
Okay, everyone, we're here. We are so glad that you're here with us. My name's Rebecca Buller, and this is the Wayside Women's Services Echo. And what we will do is start today with introductions. Now, I don't have a lot of faces to go with the names, and that's okay. You don't have to use your camera, but if you are comfortable doing so, we'd love to have you join us so we can see you. Let's start with, is it PWRAM 23? Could you unmute yourself and introduce yourself, please?
Rick Moldenhauer in the chat there.
Okay, hi. Oh, sure, I thought I knew that. Rick Moldenhauer is with us from DHS. Lucia, why don't you introduce yourself as long as we can see you?
Hi, everyone. I'm Lucia Diaz-French. I'm a certified peer recovery specialist, and I'm education and prevention coordinator for Wayside.
Thank you. How about LORIR? Who is that, please?
Hi, Rebecca. It's Lori.
Oh, hi, Lori.
Hi.
That's who it is. I never thought of your name that way. Welcome, Lori.
Thank you.
Lori's at Wayside and works both at our family and women's treatment centers. Tony Bondi, could you please introduce yourself and let us know where you spend your time?
Yeah, this is Tony Fondi from Minnesota Adult Teen Challenge. I hope you can hear me. I'm on one of the high-tech Teen Challenge computers today. That's why you can't see my face.
You're not in the car.
Not in the car, at least this time.
No, we hear you just fine.
But yeah.
Thank you.
I'm working as a peer recovery specialist at the Hennepin County Jail 14 Challenge. So
Great, thank you. A. Barnes, 2. Could you tell us who you are? Is that, okay, Angelina, is that you, hopefully?
Yeah.
Okay, let's go to DJ Morris. Could you please introduce yourself? She's not showing a microphone at all.
It's Deb Morris.
It's Deb.
Yeah.
Deb, welcome. I know that's you, and I know sometimes you have technology issues being with the federal government. So we we welcome you, and if you can ever talk or let us see you, we'd be happy to have that happen. Okay. Yep, she can't use her microphone. Let's go to someone at 218-878-36. You guys have to realize how far away this number is for me to read. Yeah, someone at the 218 area code. Could you introduce yourself, please?
Hi, my name is Sherry Willette, and I have every one of these. I have yet to be able to get onto the computer to see what's going on, so it's always been by phone. I work at Tukui Recovery Center, and I am a recovery case manager, and I work mostly with women with children and pregnant women.
Wonderful. So glad you could join us in any way you can. Your phone is just fine.
Yes.
All right. And then we have someone at a 612-200. Lots of zeros. Could you introduce yourself? It looks like you're on your phone. It may be a phone in conjunction with the computer. All right, well, we'll move on. We also have with us today Sherry Fisher. She is here and also a Wayside Education and Prevention team member. And I am ready now to turn it over to Delta Larkey with the Family Development Center and our presentation today. I think that you've indicated that it's fine to pop in with questions, and it might be most helpful if you did that through the chat. And then Lucia will let us know, and we'll bring up the PowerPoint. Once we finish and we follow up afterward with our survey evaluation, we can also send out copies of the presentation so that you'll have the information. You don't have to take copious notes at this point. And that's also when you indicate whether you'd like the continuing education certificate. So I will turn it over to Delta.
Hi, everyone. I'm Delta Larkey. I am a licensed marriage and family therapist. I am co-owner of the Family Development Center, which is an outpatient mental health clinic in St. Paul. We also have a ARMS program called Equal Footing that provides therapy in the home to pregnant and parenting individuals who are also struggling with perinatal mood disorders, struggling with traumatic birth and parenting within the first 2 years of becoming a parent. And we also are focused on recruiting and training therapists of color. And we'll get into a little bit about why that is our focus, as it is a big part of risk factors around perinatal mood disorders. What will be helpful to me, because this is a new platform, kind of doing this without having a room filled with people is if you ask questions, and it can be as much of a dialogue as possible. It helps me make sure that I am attending to the things that you want to know about, and that this will be as helpful to you as possible. So Lucia, where do I
You can just
click
click
this
on
guy
this-
right there?
You
Right?
can click anywhere on the screen
Oh.
and it'll just scroll through forward.
No,
Other
it should.
side. There
other
you go.
side.
Yep. There you go.
So we're going to talk a little bit first about prevalence of perinatal mood disorders. So research talks about how 80% of new parents experience normal baby blues in the first weeks of a baby arriving. And so baby blues is typically referred to as kind of crying jags, feeling a low mood, having difficulty sleeping outside of just what would be expected of not being able to sleep, and maybe some difficulty connecting to baby, and some worry that this is not what they expected, but then it passes pretty quickly. Postpartum depression is the most common perinatal complication. And before I go further, I want to explain what the word perinatal means. People often think about really only postpartum depression, or that mood disorders occur after the baby is born. But mood disorders can occur during pregnancy as well. And so the term perinatal means during birth as well as after birth. And so when you hear me call it a perinatal mood disorder, it's because I'm talking about during pregnancy as well as after birth as well. So postpartum depression is the most common perinatal complication, affecting 1 in 6 women, which is 10 to 20% of women, and 30 to 40% of women of color. And I wanted to point that out, because when we hear about the numbers around how many women are affected by perinatal mood disorders, the numbers are often referred to based on white women. But the prevalence of perinatal mood disorders are much, much higher in women of color. And we'll get into that a little bit later about why that is, but often it is because there are a lot of greater risk factors and a lot greater barriers. And then there's a lot of historical trauma and current trauma occurring, which creates more opportunity for kind of postpartum depression to occur. It's important to note that maternal suicide exceeds hemorrhage and hypertensive disorders as the leading cause of maternal mortality. So I name that to highlight how extraordinarily important it is that we attend to the mental health of people who are pregnant and postpartum, because suicide happens, and happens more often than we may believe. So I'm going to talk a little bit about racism, and a little bit of context as to why this, I'm talking about this now outside of that it always needs to be talked about, is the reason that the Family Development Center started their ARMS program was because as an outpatient mental health clinic that was serving individuals along the reproductive spectrum, we were finding that we were serving mostly white middle-class women. And although we were happy to be providing services and helping people, we started to dig in a little bit about why that was happening. And it was not a surprise that we were learning that the common barriers that women of color often find or experience in accessing mental health care were around childcare, transportation, and not finding providers that either look like them or have a shared experience, a lived experience. And so that's part of why we started our ARMS program, to address some of those issues, where if we provide in-home work, we can address the childcare issue as well as the transportation issue. And the teaching clinic that we started, which recruits and trains therapists of color, works to address the being able to provide therapists that both looks like them and can have shared experiences. Because the concern that, and what we're learning more and more about, is that African American women die at 3 to 4 times more in childbirth than white women. And when we control for all the variables, the only reason that is racism. Black women cannot buy their way out of it. They cannot educate their way out of it. It is truly because of implicit bias and racism that women, African American women, are dying more often. And so this is needing to be addressed. And so what we are trying to do is begin these conversations where we can, which is, in our little slice of the world at the Family Development Center, and figure out how we can attend to some of these barriers. Any questions about this so far, or any experiences that people are having in their own workplaces, or seeing kind of how this is coming up for them? No, nothing? Nothing? Okay. Let's see. So I'm going to talk a little bit about the definition of a perinatal mood disorder. So again, it can begin anytime during or after pregnancy, and this includes loss. So it includes miscarriage. So to be clear, a person can develop a perinatal mood disorder after a miscarriage as well. It might merge with baby blues. So what maybe starts with baby blues can then develop into a perinatal mood disorder, or it can start later. The onset could be when a person returns to work. I see that quite a bit in my practice. It can often start after a person weans from breastfeeding. It really can occur anytime within the first year postpartum. Some common triggers for a later onset is rapid weaning, or any sort of later, like anytime you wean from breastfeeding, beginning hormonal birth control, increased family stress, so again, returning to work, an illness or a hospitalization, or loss and grief. So again, it is not uncommon that I will start seeing a client right when they are returning to work, because they're trying to first manage, when will I pump? Where is my kid going to daycare? How am I going to leave them? And then managing the mental load of all of that as well, which often falls on, in a heterosexual couple, the woman in the relationship, which often adds to her stress, which can often lead to depression and anxiety as well. So some of the etiology of a perinatal mood disorder. So genetic predisposition. So it's important for people to kind of think about, and you can do this with those that you work with who are pregnant, is to be curious with them about, did you have a sister or an aunt or a grandma or a mom that struggled postpartum or during pregnancy? Have you had difficulty during your menstrual cycles? Have you ever been sensitive to hormonal birth control? what was it like for your mom when she became a parent? I always ask that. That is the question I will always be curious about, because it will give all the information of what it will be like for that parent. Inadequate support. Who do they have in their circle? If they have anyone. Do they have a partner? Is that partner sober? Is that partner supportive? Is that partner safe? Is that partner even around? What about their parents? Are they safe? I mean, so on and on. Perfectionism, or this idea that they need to be a superhuman person, they need to do it all and they need to do it perfectly, is always a setup for particularly a perinatal anxiety. And then additional kind of concurrent stressors, sleep disruption. One thing that seems counterintuitive, but your parents need to sleep. So they will say, well, how am I supposed to sleep because baby is always up? You need to sleep. So when baby sleeps, you sleep. I know how hard that is, but you need to sleep. And so if they do have a partner or some sort of support person, they need to come over and they need to sleep, or they need to be there so that the parent can sleep. If that means that the baby needs to take a bottle so that they can sleep, they need to sleep. Sleep is essential, and coming up with plans on figuring out how to help them sleep is absolutely necessary. Poor nutrition, other health challenges, interpersonal stress, and of course, cultural stress and barriers. So different types of perinatal mood disorders and their symptoms. So postpartum depression and anxiety are the ones we kind of see most commonly. So sadness, crying jags. So what is the most common complaint, and what you should be listening for when people come in and talk to you is, I feel really overwhelmed. Whenever someone says that to me, I am immediately kind of paying attention to, like, okay, what else is going on? Irritability, agitation. There's something called postpartum rage. Sleep and appetite disturbances. So there, a lot of times parents will come in and say even when baby is sleeping, they cannot sleep. And they are trying to sleep, but they just can't, and their mind is racing. Apathy, exhaustion, and then a lot of physical symptoms, dizziness, shortness of breath, shakiness. I'm going to pause for any questions again. Anything? Any thoughts? Any of own experiences? Anything sounding familiar?
Yes. All of it.
How common is the genetic predisposition you usually find?
It is, what I find is more common, and it's hard to kind of tease it out, is that there is the, how would I describe this? Like, we parent based on how we were parented,
Mm-hmm.
and the experience becomes imprinted on us. And so if our parent was depressed, that becomes imprinted on us, even in our like tiny, nervous systems. And so as soon as we become parents, like a light switch turns on, and all of that history starts to unfold within us. And so that's the thing that gets turned on.
Yeah.
So it's hard to kind of tease out like what's genetic,
Right.
and what is kind of like our nervous system being like, oh, I know what's going to happen here, if that makes sense.
Yeah, that does. Yeah.
PTSD and OCD. So what we see a lot, and I think I will get into this more, is PTSD as a result of a traumatic birth. And it's really around shattered expectations, as well as, believing that you or your baby was going to die. And I think this is later in my slide, so I'll talk about that more there. And what's really important, and what I'm sure all of you know about trauma, is that it's in the eye of the beholder. And so always holding that in our minds as we are working with the people that we serve, that when they come to us with a trauma, it does not matter what we think about what the trauma is. What is important is how they feel about what the experience was.
Katie had a question, actually.
Mm-hmm.
Katie, I'm going to read it off, but also feel free to unmute yourself and jump in if you want. But Katie chatted in. So a lot of these symptoms are very common for many different things. Besides the woman being pregnant, how else can you tell for sure that it's PMD?
Right. So the main marker of it being a PMAD would be kind of when it's occurring.
Okay. Timeline. Yeah.
Yeah. So, so if they show up and it's occurring, and they're not pregnant or postpartum, then you're working with something different. But if they are pregnant or postpartum and these symptoms are showing up, then you know that you're dealing with a perinatal mood disorder. And what's most important about that is then how you intervene. So, symptomology, Katie's exactly right. Like it's depression, it's anxiety, it looks the same. But the questions you ask, how you intervene, that's the stuff that's different.
Yeah. Here, Katie, I can unmute you as well and see if you wanted to chime in. Yeah, let's see. Let me find you. Here you are. Katie, did that answer your question? You're unmuted, so you might have a mic. You should have a mic on your computer. Well, feel free to chat if you have a follow-up question, Katie, or anything else.
Okay. Yeah. So we're going to talk about perinatal OCD, and this is where a lot of people start to get a little bit panicky because they immediately start to think about psychosis. And so I'm just going to talk about it briefly because I don't want people to panic about psychosis. Because to be really clear, postpartum psychosis is so extraordinarily rare that it's really it's worth mentioning. But as soon as you see it, you will know that you're dealing with something severe, and you will immediately get all the help, and you will get a team of people, and this person will be helped out. So perinatal OCD is common. So that's part of the difference. It is intrusive, repetitive thoughts, and it's usually around harming the baby. So that's where it starts to feel scary. But the difference between the two is that the person who is having that thought feels awful and horrified by these thoughts. They cannot believe they're having them. It is terrorizing them. They want them to go away. And so that is how you know that you're dealing with perinatal OCD and not psychosis. And then they start to engage in kind of some hypervigilance and compulsive behaviors to try and make those thoughts go away, to soothe the anxiety around the thought, and avoid things that are related to the scary thought, minimize triggers. And so a lot of what we do is around normalizing, soothing, and then, kind of very basic CBT type of interventions. But it is incredibly helpful to the parent to just know that this happens, and that they are not a bad parent, and that this will pass, and that they will be okay. And so So just to be clear that that is how those are different. Any questions about that? So risk factors, again, family history, personal history, symptoms during pregnancy, history of mood disorders. So for a lot of the folks that you work with, they probably have history of mood disorders or have family history of mood disorders. And so that is something that you will want to really be talking with them about or thinking about as they are either pregnant or considering pregnancy or becoming pregnant. Additional risk factors, inadequate social support. So I imagine that's something else that you see. Interpersonal violence, which I imagine is something else that you'll see quite a bit. Poverty, high stress parenting. So that's parenting lots of kids or parenting under stressful situations. So, you know, we work with families where they are in shelter or homeless and highly mobile, or, you know, one parent is in or out, or one parent is addicted, or one, you know, and so that type of parenting dynamic or single parenting is definitely a risk factor. So breastfeeding is also a risk factor. And so to be clear about this, we live currently, and this kind of a bit of a pendulum, because there was at one point breastfeeding was a thing that no one did. And now we're kind of at this other side where there's a lot of shame around, you know, breast is best. And if you don't do it, you're, you know, not being a good mom. And that creates a lot of anxiety for parents who can't do it or have not been successful around doing it. And they will not be able to sleep. They will create really rigid routines around it. Baby will not get enough food, then will lose weight, and then they can get really rigid and overwhelmed by it, and it can create lots of rigid thinking and overwhelm. And so our point of view is fed is best, however that happens, because the mental health of the parent is the most important thing, and the baby getting the food it needs is the most important thing. And so supporting the parent in any way that's necessary. And then the birth experience is also a risk factor. So checking in again about any questions or thoughts or anything. So this is just a good checklist to have. And when you get this PowerPoint, you can just kind of keep it with you, that you can check in with your folks about. Is it hard for me to ask for help? Have I had trouble with hormones and moods, especially before my period? I was depressed or anxious after my last baby was born. I've been depressed or anxious in the past. My mother, sister, or aunt was depressed after her baby was born. Sometimes it's hard for me to slow down. I don't need sleep, or I have lots of new ideas and feel very restless. My family is far away and I don't have many friends nearby, or I don't have the food, money, or housing I need. Those are just kind of like a small condensed risk factor checklist. And you can add to those, because I'm sure that you would have, knowing the people you work with, many more things that you would know. And you could even kind of work with your folks around other things that they could think of to add to that. Mm-hmm. So other kind of considerations, and some of these are a bit of a repeat, but it's because they are so crucial to the outcome of the parent's mental health. And so again, interpersonal stress, an unsupportive partner, poor relationship with one's own mother, Ambivalence about the maternal role. That's actually quite common, that like once the baby arrives, the parent feels like, I made a mistake. I don't want to do this.
I remember that.
Right?
I wasn't supposed to do this.
Yeah.
Yes.
This is too hard. Past experience of trauma, chemical dependency, and previous unresolved losses. And psychosocial stressors and populations that are at greater risk. So again, lack of social support, complicated pregnancy or delivery. So families that are have babies in the NICU, premature delivery, an unwanted pregnancy, infertility issues, a sick or colicky infant, multiple births, a stressful life event, single moms, low-income individuals, socially isolated individuals, or recent immigrants. So substance use and pregnancy. So I just have a little paragraph here. I'm just aware of time though.
This is a good one.
Oh, you want me to go back? How do I go back?
Yeah, if you click on the left
This
arrow.
guy.
Mhm.
The incidence of substance abuse among women of reproductive age continues to increase, thus contributing to the growing problem of substance abuse during pregnancy. The highest rates of alcohol and drug use are among women in their childbearing years. Greater than 50% of women aged 18 to 35 years responding to the National Institute on Drug Abuse household survey reported that they had used alcohol in the past month, and 5% reporting illicit drug use in the same interval, with marijuana the most frequently used of the 4 million women who became pregnant each year. At least 20% smoke cigarettes, 19% drink alcohol, 20% use legal drugs, and 10% use illicit drugs during their pregnancy. Thus, substance use is highly prevalent in pregnant women. I don't know what that little guy was here. I think I had something else. When I was doing some research, what I was learning, and this will be no surprise to any of you, is that marijuana use during pregnancy is huge and on the rise.
Do you think it has to do with nausea or not?
No.
Okay.
No.
That's my first thought, is, I want to be able to eat and not be sick all the time.
Yeah.
But probably not.
No. What I would wonder about, and this is based on no evidence, just my own brain, so is that having worked in chemical dependency as well in the past, is that people often in their justification feel that marijuana, it's herbal, it's natural, and so they find ways to justify use differently. And so I don't know, what do the other folks think about why there might be increased use of marijuana?
I think in the sense that it's probably normalized more than other drug use.
Anyone else have an idea of why that might be a common use choice?
Let's see in the chat here.
I see Tace is here.
Yeah, she's signed on a little bit later. In my experience, I've had friends who use small amounts for nausea.
Okay.
Yeah. Okay. So things to remember. So perinatal mood disorders are common and frequently undetected yet treatable. Protective measures can help a pregnant person avoid suffering and greatly reduce the length and severity. So protective measures, or how can we support the person proactively? How can we be mindful of their support network? How can we know their history, know what it was like for them, their own mood disorder history, so that we can kind of put plans in place as much as possible. Early identification, cultural competency, and responsiveness and humility to client vulnerabilities is really essential. And then psychoeducation and wellness planning is necessary for a healthier outcome. Okay. So I know that there were going to be questions at 12:40, and
But you can keep going.
Okay.
Yep. Well, we can go another. I would say we're not like overrun with questions, so we're going to keep going, and we'll take another like a formal break around 10:02 to see if there are questions. But go ahead.
Okay. So I want to be sure to talk about birth trauma because particularly for those who are working with people who are pregnant or going to be pregnant again and have histories of trauma or sexual abuse trauma, having some knowledge about kind of the experience of birth trauma and how to prepare a client for going into birth is going to be really, really important. I work with individuals all the time that are coming to me because they've experienced a traumatic birth. And there is some of that the work needs to be done with medical providers, and hospitals are doing more and more work around trauma-informed care. And then some of the work that I do is how to prepare my clients to have autonomy, learn to ask for what they need, know that they can say no, that they can have different providers, that they get to be in charge of how their body is touched or not touched during their exams, which for a lot of individuals who've been sexually abused, or who, all of us that kind of live in this hierarchy, medical hierarchy, don't often feel like we can go and say no to a doctor, or we feel like they're the experts and we do what they say. Mm-hmm. And so helping them kind of develop a sense of agency has been really, really important. This is particularly crucial for women of color because birth trauma and the experience of trauma in birth is far more prevalent in communities of color. And there's a large historical history of trauma around women of color and their bodies, particularly if we even look at African American women and gynecological care. And all that we know about that was because of what was done to African American women. So, and I think it's important that we hold all of that in our minds because women are carrying all of that in their bodies. Mm-hmm. So, birth trauma risk factors. Some factors increase risk of developing PTSD after a traumatic event. So including just being female, women may be at risk, increased risk of PTSD because they are more likely to experience the kinds of trauma that triggered the condition. Experiencing intense or long-lasting trauma, having experienced other trauma earlier in life, having other mental health problems such as anxiety or depression, lacking a good support system of family and friends, having first-degree relatives with mental health problems, including PTSD and depression, history of abuse, such as childhood abuse, sexual abuse, rape, or combat exposure. Now, if you think about the people that you serve, I imagine that would be most of them. Mm-hmm. So that they meet kind of all of that criteria. Mm-hmm. And so that's just kind of an important thing to consider, that they meet all these risk factors for experiencing birth trauma.
So as your people are pregnant and developing birth plans, and I think, how do you then have the conversation of like, how do you want to have your birth go? What would feel good to you? What wouldn't feel good to you? What are your kind of lines in the sand? Where can you be flexible? Because having flexibility in birth is really important. And, you know, and being able to have those kind of conversations will be really, really important.
Especially for first-time moms.
Oh my gosh. Yes.
I remember how much more agency I felt the second time.
Yeah.
And I would say things like, I will not
Yeah.
wear that gown.
Right.
I will wear what I am comfortable in. And getting some kickback and saying, no, I don't care if you have cut it off. The flexibility was, it's old, you can cut it off, you can do whatever you want to it.
That's right.
That was the flexibility that we built in, so that I could be in charge of those moments. And just, it made a huge difference.
That's right. And part of it is because, like, with a first-time mom, you don't know what to expect. Like, you don't know. So your brain is just afraid because it doesn't know that, like, you're not going to die. Where the second time, it's like, you will survive this. You're going to be okay. Like, here's what's going to happen next. Like, you know, but so it's just, you really are terrified. So external factors that can lead and add to birth trauma: feeling isolated or alone. So doulas are amazing. So Everyday Miracles is a great organization that have doulas that they provide doula care, and Ahava Birthworks also provides doula care. They are both doulas that are have a lot of doulas from communities of color. The Ninde Collaborative, they provide doula care, and it's free of charge. So if you have undocumented people, they don't need to fill out any sort of identifying information. Unkind hospital staff, long labor, long pushing, long periods of not knowing what is happening or not having a voice in what is happening, unplanned C-section, missing periods of the birth because of medication, helplessness, feeling out of control, the pain, because the pain often surprises, particularly first-time parents, and onslaught of interventions and feeling like you don't get to decide about that.
You mentioned Ahava Birthworks,
Yeah.
right? Yeah. Angelina was excited by that.
Yeah, yes.
I was thinking that I want to just make sure we catch those names of the doula resources and we'll send them out.
Yeah, and I can send a follow-up.
That'd be great.
Okay, we're going to move to grief.
Are we going to end on grief?
We're going to end on grief, probably. So my focus at my clinic is working with pregnancy loss and infant death. And so grief is, and death and dying is my favorite topic, believe it or not. I love talking about grief, and I love talking about dying, and mainly it is because I have found that the closer you get to death is the closer you get to joy. And so I have a particular fondness for this topic. But I don't like culturally in the Western culture how we talk about grief, because you get about 15 minutes to be sad. And then it's like, now you need to be done, and don't put your sadness on me because I'm uncomfortable by it, and like move it along. But grief is normal. It is a normal response
to what feels like an abnormal circumstance, but is the great common denominator. We will all die. We will all experience grief. We will all experience loss. And the things that I want those that work with people who lose their beloveds, like those of us who work with those who lose their loved ones, is to manage that rage to cure, that to pause, that people must go through it because grief will wait. Mm-hmm. And that we mourn as much as we love. And so let those people mourn. And that norms regarding grief are based on one population, so it does not generalize to all others. So I am not an expert in the cultural ways of all people and how they grieve, but I can be really curious about it. And don't rush to medicate. I am always really, really, really frustrated when, like, a mom who experienced a stillbirth 6 weeks ago has come to me and then at the 6-week appointment was given Zoloft because she lost her baby. And of course she's sad. She's not depressed. She is mourning her child. And so part of our job is to pay attention and be with that mom. And certainly this could become depression, but like, pause, be with. She has lost her child. So let's not pathologize because grief is not treatable. Social constraints and grief. This is one of my favorite quotes, when a flower doesn't bloom, you fix the environment in which it grows, not the flower. Because I think oftentimes what people try and do is when someone is grieving, they try and fix the person who is grieving instead of like creating space in the environment for them to just be sad. The most salient identifier for a maladaptive behavior in bereavement is social constraint. So it is the people around them saying, don't you think it's time to move on? He would want you to date, like, she's in a better place now.
You can have another baby.
You can have another baby. It's a good thing, that you didn't know her, that she died before she was born, The first question I always ask a client when they come in around loss is, how have other people treated you since your beloved died? Because that's really what I want to know. Because once I know how they've been treated, then I know what I need to be working on. Say the child's name, remember their birth date, remember their death date, ask to see pictures, ask about the birth story, be curious, be non-judgmental. This is not about your discomfort. And if you're there, which you guys probably wouldn't be there, so I'll pass that part. And so talk about the baby. You will not remind the parent. You will not make them feel more sad. They are thinking about their baby all the time. Because that's a thing people always say, like, oh, I just don't remind them of the baby. You're not asking about them. They're not going to be like, oh, they feel good. And there's no timeline for grief. So I often think man dies of the cold, not of the darkness. So.
Would the same kinds of things apply to a parent who has lost custody and may not have that child, may have fears of not having that child reunified? So they would have some of those same grief feelings? Because I think that's going to be a situation that we may run into a great deal in working in this field.
Like their rights have been terminated?
Yes. Or even temporarily, or they were incarcerated and now they're in treatment or whatever.
Yeah. So you work with grief. You work with grief around what are you missing? What have you missed? Creating the narrative around that. What does it mean about them as a parent? Yeah, you're just with them in the grief.
And it's just, yeah, there's no moving through it. It's just being in it. Yeah.
Okay. I saw parallels happening in my head and wondered if
Yeah.
it was appropriate.
Yeah.
Okay.
I think it's important to point out that the grief applies to miscarriage too. So a lot of time people are like, hey, you're just 6 weeks pregnant, or it was like, meh. People, we didn't never know unless you are curious and ask how someone conceptualized that pregnancy, that baby, who that baby was to them. And so that, like, when somebody becomes pregnant, there could be one person who thinks like, oh, it was just a bundle of cells and on we go, and I'm just going to try again next month. But there's somebody else who has created a entire life. If that baby had a name, they imagine bringing that baby to kindergarten and the wedding. And so like there's an entire life that has been lost.
Yeah.
And so we attend to it in the exact same way. So miscarriage is often obscured and people's grief gets dismissed constantly around that. And so being mindful of holding space.
This is amazing. Now, is there more beyond your resources? Or are we?
I think
we're at the end?
I think we're done.
Okay, good.
Yeah.
Yes. So we'll send those resources out, and you'll have contact information, and we'll try to grab those doula resources and add that to
Angelina chatted them in as well.
Pardon me?
Angelina chatted them in as well.
Okay,
The
wonderful.
Doula resources.
Oh, good.
Oh, wonderful. Now we have recorded this, this presentation. So we think it's automatic, but I like to double check. And it will be posted on our website. So if you have colleagues who could benefit from any of this, please let them know they can watch it in any time in the future. We keep it in our archive under Echo on the Wayside Recovery website. Please be sure that if you haven't, and we can't, like, if you haven't checked in through the check-in, be sure to send a note to Lucia so she can get your attendance and respond with our evaluation survey and opportunity to sign up for the continuing education, and we'll send that certificate out to you. That evaluation is really helpful to us in moving forward, and we also want your ideas for topics and presenters, and we'll pursue that. Be happy to be the legs on the ground here. Invite your colleagues to join you for lunch at your office and participate, or from their office. We have plenty of room, and anyone and everyone is welcome. And if you'd like to volunteer to present a clinical topic, a resource that's very helpful to you, please reach out to either me or to Lucia. We'd be happy to have you. And I want to let you know about an opportunity we have coming up on Friday, a week from tomorrow. It will be an educational topic, and it's one of our Friday Forum series. It's called Understanding East African Clients with Co-Occurring Conditions, Somali 101. And Yusuf Shafi, if you heard him, he was on NPR this week. He had founded the Alliance Wellness Center. And I'm really looking forward to that presentation. It's a 2-hour approved continuing education experience next week from 9 to 11 on Friday morning. And you can sign in from wherever you are. We also have a few seats here. So if you would like to come in person, we can also make some room for that. Again, just email us or go to our website and register there under the Professionals tab and Friday Forum. I want to thank everyone for being here. It looks like a few people signed in after introductions, so hopefully we'll catch you next time. And have a wonderful couple of weeks, and we will be together again in October, the first Thursday in October. Goodbye.